Welcome to our podcast, Sculpted and Unscripted with Dr. Azad. This is an opportunity for Dr. Azad to answer questions that regularly come up during consultations, pre-ops, and post-ops.
Our viewers have been asking about the internal bra. Would you be able to tell us a bit about that?
Yes, of course. That's very actually common. I see it on every consultation, people asking about internal bra, and it's important. So that's something that I do on every primary augmentation, the first time augmentation, and also the secondary augmentation. So what essentially the internal bra is kind of like a support structure to hold the implant, because what you don't want is the skin to be responsible for the weight of the implant, because the skin will stretch over time, and that's why you see people over a period of time they have like a saggy breast or the breast droops. So you want to place this support structure. Now there are different types of internal bra. The one that I like to do is like using your own tissue. So what I do is like creating the internal bra. I create like a scaffolding structure like that, but that's using your own tissue. The kind of terminal name for it is mammary fixation sutures. So what I do is like where you have your own natural fascia, which is like a superficial fascia, I tack it down to the thoracic fascia if I do place the implant submuscular or ductal plane, or tack it down to the pec fascia if I do a subfascial. So it's not anatomical is a structure, but it's what it does. It's like hold the implants. There are other ways, they can place an actual mesh. What I don't like or do like about the mesh is like if you operating on, most of my patients are moms or like someone that they're young, so their own tissue is already strong enough to support the implant. So that's why I rather do it using your own tissue rather than placing a mesh, which is something foreign. However, is there a room for like a Galaflex or Dorzorb mesh? Absolutely. I use that on cases that patient already had an implant and they already had a malposition, the implant already bottoming out. So in those cases, their own native tissue has already been stretched, has already been through war, So in those cases, yes, I do the capsulorrhaphy, which is using their own tissue, and on top of it, I placed the mesh. The other people that I would think that would be a good candidate are the one that have a massive weight losses. Like, we're talking about like 100, 150 pound weight loss, because in those situations, then your ligaments or your skin elasticity is extremely poor. So all your Cooper's ligament or support structure, your superficial fascia that we use for internal bra, it's super weak. So in those cases, I use the actual mesh. But in regular primary augmentation, I use your own tissue as an internal bra, and I have to say, I haven't had any issues, as far as in my malposition, or I would say maybe out of 100, I get one person that has an inferior malposition. In that case, then I go back to the to the mesh. The other thing is with the mesh, again, it's still new. We don't know how this will affect in about next 10 or 15 years. So I pretty proponent of only use it if you need it, and actually I was going to ask you, like, and as far as the recovery, when we do this internal bra, when they're coming the next day, do you feel like they're having pain or they have any special
No,
soreness?
I think the only question that they really have is about where the incision is and how it's a little shaped different with the internal bra.
Exactly.
Yeah.
I'm actually glad that you mentioned it. So once we do that, as I mentioned, remember, this is not an anatomical suture. This is not anatomical. So you're going to have, and I tell the patient, you're going to have a little bit of a fold or divot in the beginning, because that been tightening to the thoracic fascia to hold the implant up, but that will pop out in about 3 months. And it's going back to normal, because by then you develop enough scar tissue to keep the implant up. Also, when we do this secondary augmentation, those are the cases like we're doing like an implant exchange, So in those cases, I still use internal bra, but in that case, they already develop a capsule. So the capsule is actually the best possible mesh, because that scar tissue is already formed. So I kind of use that, reinforcing it again to the thoracic or a pec fascia. as an internal bra. And I think in those cases, I rarely do a mesh in those cases because, again, that capsule has already been formed, that scar tissue is already formed, unless they already had an inferior malposition. Unless that the implant already blew through the original capsule, then there will be a need to place a Durazorb or Galaflex mesh.
And have you always done the internal bra?
Yeah, actually, it was part of my training in cosmetic surgery. I always learned how to do an internal bra. Do you have to do an internal bra? I mean, I'm a big proponent of that. Do you have to do it? No, not necessarily. You can just, close it in the same anatomical fashion. But again, at that point, you're letting superficial fascia and the skin dictate the weight of the implant. And I know in over time that will stretch out. So I'm a big fan of putting an internal bra primarily.
And what are the consequences of not doing one?
Same thing, you increase the risking of inferior malposition, essentially. And especially if you're placing large implants, you're increasing the risk of inferior malposition.
Thank you for joining us for Sculpted and Unscripted with Dr. Azad. Join us next time for another exciting episode.